I got it.
Okay,
I
thanks.
recorded it. So, welcome to the first time I've ever done this. I'm doing this as an open forum for HESI review. What I have done, I've gone back several HESIs and looked at the concepts that are in that, and especially those concepts that are missed. So I don't have questions. I don't know what the HESI is, but I can figure out maybe what they're looking for. So if we discuss something, we'll figure it out. So let's start out with I have put them in different sections: nutrition, different ages of children, and then I'm putting it into systems of the body. So we can group them together and see how they all relate in there, okay? So nutrition, nutrition, nutrition. What do you know about nutrition? And what do you know about children? How about infants and nutrition? What happens if they don't get nutrition?
They don't grow properly.
They're going to be growth and development behind their cognition. They need fuel for the mind. Okay, what if they have reflux? They're losing food. Again, what's happening?
Dehydration.
Well, besides that, they're not getting nutrition, right? Of course, you always will watch out if you get a child coming in with vomiting, and it's just dribbling. So we know it's just reflux, not projectile, as in pyloric stenosis. We know that they're not getting all their food. So how do we treat reflux in the younger child? Simply, before meds.
You set them up after eating.
Well, yes, we can set them up. We can burp them well. We can not overfeed them. And we could put a little rice cereal in there. Now, you're told not to put food before 6 months. They're not going to use that for food, but it thickens it and holds it down. And that's the first way that we will treat it, after what Mindy said: burping them, making sure they're sitting up, and making sure that you don't overfeed them. So rice cereal, very simple. You might see it in the stool, but it's okay. All right, what about you have a child who's obese? You have a school-age child, they're obese, and they come in and you see that their BMI is getting too high. What are some things you might ask a parent about this? How can you track it?
Their eating habits.
Like, let's do like a 2 or 3 day diary. Let me know what the kid eats. How about physical activity? Are they active? Do they go outside? Or are they the video game kids, right? How about at school? Do they have PE at school too? I mean, these are key things that we need to know to get a child who's obese. Because remember, school-age children learn easily. You can teach school age, and they're pleasers, right? Piaget says they're pleasers. So we want them to understand what they need to do to please. And again, it's not through criticism, it's through that reward, right? And giving those little steps that they can accomplish, because that's industry. In Erickson, I have this goal to do. I can accomplish it if I work for it. And that is a feeling of satisfaction. That is your industry. Industry versus inferiority, right? They can't do what they can't do. And then celiac disease. What do you know about diet and celiac?
No wheat rye or oats.
Or barley, brow. Think of brow. Barley, rice, oats, and wheat. I had a project come to me on the celiac disease, and there was a little picture of a kid with these big brows, and I'll never forget that. It really makes sense. So if you had to look at a food tray and remove something, remember, those are the items. Crackers, I mean, would be something that we would remove from the tray. Bread, anything breaded, because we don't know what type of bread that is. Okay. Infants. Well, we know infants go through a whole set of different fine motors and gross motor things. We've gone over them and over them and over them. So let's say you have a infant and you're doing your morning assessment. On the morning assessment, we're going to, of course, listen to the body parts. We're going to measure the abdominal girth to make sure that they're getting nutrition and it's not getting too big, which would show you something else is happening, like the food's not passing, which could be a food intolerance, or it could be necrotizing enterocolitis, which means the intestines is dying. Now, the other thing we do is head circumference. Why do we do head circumference? What does it look at? What if it's getting bigger? What should you do? What's going to tell you there's a problem? The head's getting bigger. What do infants have? A fontanelle. Is that getting big?
Sometimes.
It could be hydrocephalus that's occurring that you're just finding out. And that's some of the first clues that we'll see that there's a problem. Could be even a brain tumor, and infants do get brain tumors for whatever reason. So you could be the one who says, you know, this is up an inch from yesterday, or last week I had the same child and I know I measured it well. I know it's gone up. Tell the doctor and they'll start an exam. And you may be that person who helped that child get better quicker, okay? Okay, toddlers. I think toddlers, preschoolers, when we look at them, remember how we go and we approach them. These are your scariest children. How do we go in? What do you do first? You've got to go tell them you need to give them a shot. Go in on their level, right? Hey, you got, oh, wow, that's a Batman shirt. You know, I've got a Batman shirt too, but mine is this color, but yours is that color. Oh, where did you get those freckles, right? That curly hair is amazing. And who put your hair in those ponytails? That is adorable. You're on their level, okay? Sit down on their level and let them be aware of exactly what's going on. Children, even toddlers, need to know that. Now, if they're going for a procedure, and today we are so lucky, we have Child Life. So Child Life does a lot of this work, right? They will take a doll or something to show on them where they're going to be touched or what's going to happen to them with the procedure, so that when they get to do this procedure, they're not freaking out, because these children will get up and run down the hall. I can't tell you how many times security had to go chase a kid out of the ER for me, okay? Usually not my child, but another one's. Or I'm in triage and the kid's running out the door and they say, get that kid. It happens. Why? They're afraid. So we do that, get on their level, let them touch and feel the equipment, and then use a doll for things that you might need. And then they understand. Some of them need a visual, not an auditory, just like same type of learners, right? Okay, autism is usually diagnosed at the ages of 2 to 3. We don't before then, although we may see signs and symptoms that they could be autistic. There are different forms and checklists that we can use, okay? There's not really mentioned in class a lot about them, but it's in your book. And it's all about, you've got a kid who now is doing these really odd behaviors. What would be an odd or repetitive behavior? Now, I use my one little kid from daycare. You take a truck, put it on the chair. You take a doll, put it on the truck. Take a blanket, put it over, right? And then you take the blanket off, the doll off, the truck off, and you do it over again. I mean, there's many other things we see in autism too. What would an autistic child, what else would you see beside those behaviors?
Not receptive to
using the
noise.
eye,
They don't like noise. They don't like what? Did you say, Nicole?
not looking at you in the eyes.
Right. They don't like that. It's an invasion. They don't like touch, lights, people, okay? All of those things. So then there's something called an ages and stages questionnaire, which can look at it. And there's also a checklist for autism that they will go through and check so that they could get to the psychologist in order to get, or neurologists to get what they need. And we know with autism, the way that we help them is doing the same thing, same time, every day. So schedule, schedule, schedule. Okay, school-age children. As school-age children, we're starting to see them get them in the hospital. Some are in there for a long time. And one of their worries is all about their brothers and sisters at home, or their nephew, or somebody that they care for. I mean, how would you have this child who's stuck in the hospital due to whatever? How would you make them feel better about those people at home they left there?
Have
What
them
would
come
you do?
visit.
Hmm?
Have them come visit.
It's COVID, they can't visit.
Video chat.
Video chat, yeah. How about a card? I've mentioned how I put bows in kids' hairs and I send them home for their sisters or their cousin, right? Little things that make them feel like they're thinking about them. And then, of course, conversely, the kids at home can do something for them. I mean, we're lucky about FaceTime today. I didn't have that many years ago, so I had to be creative in what I did. And those creativity things is something to hold on to. Video chat, once it's done, it's gone, right? But these things they can touch and think about their brother, their sister, their cousin. Okay, you've got a school-age child. We know every visit, every kid, what do we do every visit? First thing,
Vitals.
before that, part of the vital signs. Height and weight, right? What does height and weight show us?
Growth patterns.
Okay, yes. It tells us nutrition, right? Are they eating enough or too much? Also, what if they are progressively getting shorter?
Hypoparathyroidism.
It could be, or what else could it be? The family's short. Nobody in the family's tall. It could be as simple as that as your answer, okay? So think out of the box. Don't just think those things. These things are something that will be taken into consideration. Now, what if they're too tall? Are your family tall? Well, what if they're not? Then we're going to look for hyperpituitaryism. Maybe it's a tumor on the pituitary gland. So you see how height and weight is huge, really is, and could be answer for many questions, whether it's about thyroidism, hypothyroidism. It could be on pituitary problems. It could be on obesity, could be nutrition. So many things are evaluated with height and weight, okay? Does that make sense? Okay, adolescents. Now you have adolescents that are put in the hospital, and we know adolescents only want their buddies in them, as I've always said. You just want your buddies in them, your friends. You don't really want, at this time, when you get to the hospital, though, you want mom and dad there because you want somebody. Well, what if those friends could be allowed to come? We're getting better with visiting times and people going to the hospital, etc. What would you do for an adolescent to make them feel good if they're prolonged in a hospital? They want to see their friends. What do you think we could do? Give them a private space to sit there and talk? They want to know what's going on with their friends. They want to know what's happening with the guy that they like or the girl they like, or they want to know what's happening at school and what happened with this and that. And they don't want anybody listening. They want that private time. We know this is one thing that could open up the conversation with adolescents. Also remembering that adolescents, you got to get them to get you trust. Because remember, you're an adult. You're like a mom and dad. You're an authority figure. So asking them about what, school, asking about what music they like, they play sports, how they doing, favorite, whatever. You've got to get into them so that they open up the conversation. And that will help you get information you need. Now, if we're talking to an adolescent about sex, and that's going to be what we have to talk about, because maybe they do have frequent urinary tract infections, or they've got a yeast infection. How are you going to get that adolescent to open up to you?
Asking the parents to leave the room.
Absolutely. And the only time that we have to tell the parents what they said is if what? Danger to themselves or others, right? Absolutely. Because you need the information in order to treat that child as best as you can. You have a child who is coming in for a normal visit, an adolescent. How would you know if they're going through puberty? What's something you would do a check with? Do you remember Tanner? Tanner stages of puberty. We know the first stage is breast buds, right? And we know in males is enlarging testicles. So knowing the different stages of Tanner can make you understand where they are in puberty. And this could be related to them. Maybe it's mother was concerned about something, or they're not as where they should be, but maybe they've just started puberty and you could see it. So understanding Tanner stage is important. Okay, I've started to mention Piaget and I've started to mention Erickson. You know that HESI loves to do questions on Erickson, and they like to throw in a question on Piaget. It's going to be there. So Piaget, what does he talk about? What's his whole concept about? How things work, why you do things, cognition. How does a child think, right? If they're not thinking right, there's a problem and it needs to be evaluated. It could be they're autistic, could be other issues that are occurring that makes them not think. So remember, for instance, infants, one of the first cognitions is they put a rattle in the hand, they have that voluntary grasp, he shakes it and it makes a noise. Okay, he does it again because he remembers. That is part of Piaget. Or, my cup fell off the high chair once and I cried for it and mom came. So when I want mom, I throw the cup off the table. Cognition, how do I make things work? How do I get what I want? As we get to school age, it's how do I get the good praises? And it's the pleasing that Piaget talks about, because they understand what they have to do. I want to go to the movies on Saturday with my friends. I know I have to get a good grade on the test that I'm taking on Friday, right? I understand. Or I took the garbage out like I'm supposed to, or I put my laundry away, whatever it is, could be as simple as that. Remember infants about object permanence. Remember, if it could be infants, toddlers, preschool. They know they have it once they see it, even if it's not in full sight. That's object permanence. So again, all Piaget, understanding. Again, I'm sorry for my cough. This has been all semester with me. I'm trying to take care of it. Okay, school age children. Now again, school age in, let's go to Erickson. I'll start with infants, school age and infants. And the adolescents we can talk about too. So in infants, Erickson says that you need to build trust with your infant. How did we know that is, and what does an infant feel with the trust? Well, they know if they cry, somebody's going to come get them. They're going to be fed, burped, changed, held, whatever they want. So they know their needs are constantly met. That's Erickson. Now, as we get older, we talk about school age. We know school age is industry versus inferiority. And let's apply this to something. So you've got a kid who's in the hospital for an extended period of time, and they're getting bored, they're getting depressed, and the nurse needs to challenge, or even child life needs to challenge this child to feel a sense of industry or that they've accomplished something. Maybe it could be giving them a 500-piece puzzle, because they can do that. It's going to take time, but you know a school-age child would do it. And when they're finished, they go, look what I was off for 3 days, came back, and the kid finished the puzzle. And you're like, wow, that's awesome. So let's glue it down, you know, or let's do something so that you can keep that to remember what you did. Sense of accomplishment, feeling good, okay? Never give them that 2,000-piece puzzle they're never going to ever finish, okay? Because then you feel a sense of inferiority, right? So give them tasks that will help them to feel good about themselves. And we know Erickson is all about the adolescent sense of identity. And as a nurse, how do we talk about identity with adolescents? And it is giving them respect. It is opening it up the communication, but also when you're talking about things that could be very difficult to speak in front of parents, if the parents leave the room. And now you have given them their identity, okay? And remember, adolescent body image, body image, body image. They really are into that. But beyond that, that's part of their identity. Okay, let's do a little hematology. So you have a kid who's 2 years old, who went into the ER, into the doctors several times because they're getting nosebleeds. Well, nosebleeds, how do we take care of them? Let's start with that.
You pinch the nose and move your head forward.
For 10 minutes. What do you do if after 10 minutes it's still bleeding? They should go for medical assistance. Something else is going on. It could be hemophilia. So this little 2-year-old had been to the doctors twice, gone to the ER. Now it's the 4th time that their nose bleeds. At this point, they're going to be doing examinations. Hemophilia, what would you see? You see prolonged PTT. And that's without doing factors, right? Why is the PTT prolonged? We're not on heparin. We're not taking aspirin, right? So then this kid is admitted. We do the factors. We find out he's a factor 8 deficient. And now you've got a 2-year-old to bring home with hemophilia. What are some safety things you need to do? You don't think about that with hemophilia, do you? 2-year-old running around. You can't stop them. You can't put them in a cage. You can't. They'll climb out. What about those? Go ahead.
You could cushion the sharp edges.
Absolutely. Absolutely. That would be taught. Absolutely. And don't leave anything sharp out for them, because they bump into it, especially if they cut themselves. They're going to be bleeding everywhere. Excellent. That was a very good response, Nikki. Okay. What if this kid falls down? He's now older, 6 years old, was out riding a bike, fell down, his knee hit a rock when he fell, and the knee is now this big. What is the emergent treatment for an injury?
Elevate and ice.
It's the RICE, right? Rest, ice, contain, elevate. And many times they have their own factor at home because they have home infusions for the factors. They can do it. I had one little father who came in who I saw him deliver a factor to a child better than I could do it. And I watched his whole way, washed his hands, mixed it up. The kid picked the vein. He got it in with a butterfly, held it there, infused it out. The kid didn't whimper. It was awesome. And the kid was only like 8 years old. So they do give home infusions. So rice it, and then also give the factor maybe. Now we know that hemophilia has normal platelets, right? They're normal platelets. I mean, ITP is when they're low, right? With low platelets, what would you worry about? I don't care if they have a bleeding problem, they're a medical problem, or a surgical problem. You have a child and all of a sudden you see platelets at 20,000. What do you need to do besides call the doctor? What does that mean? It's a chance of bleeding, isn't it? This kid's going to bleed. So whether it's a kid with leukemia, whether it's a kid who's a normal kid who came in with a viral cold, or a kid with other conditions, low platelets, they need to be placed on bleeding precautions. For you as a nurse, what are bleeding precautions? What are things you wouldn't do?
No aspirin.
No aspirin, nothing bleeding, yeah. Toothbrushes.
You don't give the IM injections with bleeding
Perfect.
precautions, right?
Right, because they'll bleed underneath the skin and bleed and bleed and bleed. Because again, platelets have to do with bleeding, stopping bleeding. It's like the Band-Aid that stops the blood from coming out. You're going to be checking urine, stool, bruising, nosebleeds, anything, bleeding precautions. And of course, you'll be monitoring those daily CBCs. If they're in the hospital, they'll probably will be doing them. Okay? So platelets, I don't care what the kid is. All the time you see low platelets, you need to place them on a bleeding precaution. Okay, sickle cell disease. Priority care. They're in crisis.
Control the pain and fluid.
What's first?
Fluid
Um,
bubble.
Fluid.
Because if you do, okay, yes, they're in pain. Oh, absolutely, they hurt really bad. They're usually crying. So you start an IV, and you know that sickle cell is a bunch up of cells, and it can't get through bifurcations. And one cell gets stuck and the rest get stuck, and then you swell, causes tissue death, and it hurts. So if we give something for pain first, you're not alleviating why it happened. Okay, makes sense? Heat, fluids dilates it with the pain medicine all at the same time, but your priority is fluids, because that's going to eliminate why the pain is there. But very good, you had both of them there, so good, good, good. I mean, pain is one thing that we really need to monitor with sickle cell, and we need to give it on time, and we need to give the doses that are ordered, and make sure that we not only give it, go back and evaluate if the pain was better. Okay. Juvenile idiopathic arthritis. How are you going to have this school-age child? Many of them will be placed on things like Humira injections weekly, methotrexate injections weekly. Maybe they need prednisone. They wake up, they hurt, and it's hard to move. How are you going to have this child? Let's say they are a 12-year-old, okay? So they could give their own injections if they had to. It's just like a kid with diabetes, right? These are injections, sub-Q injections. How are we going to make sure that this kid is going to be compliant with medications? If they're not compliant, they're going to hurt, right? How about if we offer them a treat, some sort of reward, something that says, okay, if you, make sure that you're giving your stuff on time, you take your medications. I know you don't like them, but well, let's go to the movies Sunday together. Or a 12-year-old, I'll bring you and your friend to the movies. I'll pay for it. Something little to make them something to look forward to. Kids do respond to that. They really, really do. All right, in the sense of bones, you have a kid fell off a monkey bar, comes into the urgent care to you. What is your priority action? The arm is swollen, it's painful, they're crying, they're holding their wrist. It looks malformed.
Take
Number
their
one.
temperature. Stabilize the arm.
Capillary refill.
There you go, neurovascular signs, because blood supply is number one. Because, you know, blood supply, the arm's going to die. So that's number one. And then we do everything else. We stabilize it. We get the x-ray, we ask the history, you know, put the cast on, then it's cast care, which you all did the discussion question on. So it goes on from there. Number one. What about, you have the kid who comes in who fell down, let's say off the second story balcony, because I've seen a little girl do it. She comes in on a backboard. What is your priority care for that child?
Mobilize the spine.
Yes, we want to keep that spine immobilized. I told my class, I had a 16-year-old boy who went into third base, slid in, his head hit the defender's knee. These stands heard a crack. Now, rescue came, he was helicoptered out, trauma alert. He was placed on a backboard, got in. Of course, I did all my things for the 16-year-old, kept him calm, told him what was going on. I did all of those good things, got the x-ray, and the spine should be straight. It was at C5, C6. It was an angulated fracture with paralysis of the right lower leg, and he had numbness and tinglings on the left. I was the primary charge nurse on duty. He's my kid, my responsibility. I had to even do an MRI on the child. My goal, immobilization. Fast forward 2 weeks, I went to see him upstairs. He was just being discharged to rehab. He had full strength on his left leg with minimal numbness on the right. I saved him from being paralyzed. Okay, immobilization. I think you'll remember that. Okay, cardiac. Jerry, could you put your last name so that I know who you are, please? I'd appreciate it. Thank you for coming. All right, cardiac. What's Kawasaki disease? And it's not a motorcycle. It's a systemic vascularitis, inflammation of vessels. What are we most concerned about with that? What vessels would you be concerned about? And what procedure are you know is going to happen?
You're concerned about the vascular.
Where?
Kawasaki. Are these in the vascular vessels, and are these in the heart? Is it
The coronary arteries.
coronary artery? Yeah.
Yes, because they could get aneurysms. And you
Yeah.
blow an aneurysm on a coronary artery, muscle death, heart attack. It's like having a myocardial infarction. So prepare for what procedure?
Cardiac cath.
What's before cardiac cath? Come on, Ernesto, you know. What's before cardiac cath? Get the kid in. You want to find out if they have some sort of congenital heart disease.
Is it the electrocardiogram? Or
No,
echocardio-
after that. Echocardiogram.
Echocardiogram, yeah.
We want to see if there's bulging, if there's blood flow, what's going on. And you could see dilated vessels. So echocardiogram, be prepared for. Now, they're going to place this kid on something to help them. It's a viral condition. Usually these kids had, and this was my, the doctor in charge of the cardiac intensive care unit had a 3-year-old boy, was admitted one night while I was working and diagnosed as Kawasaki disease. I didn't know about it before then. Came in with these big red eyeballs, these cracked red lips, strawberry tongue, rash, fever. Okay, so now I knew what it looked like. Now, these kids, the next morning, he couldn't wait to do the echo on him because the machine was locked up, or else he would have done it that night. But we needed to place him on medication to reverse it. It's all viral. It's not a bacteria, all of this symptoms that I said. So what medications do you put on children for Kawasaki?
Is that the one with aspirin?
Yes, yes. The only time we give aspirin, high dose aspirin, and what else? It's viral. We need to boost we have to boost the immune system. IVIG, intravenous immunoglobulins, and aspirin. And it's usually about a month long. Now, this is usually something that doesn't reoccur. It's usually you get it, you cure it, you're better. And they usually will just do follow-up echocardiograms with cardiology to make sure. Okay, we've heard about prostaglandins and indomethacin. Prostaglandins, what does it do? What does it keep open? It's usually in fetal
valve.
circulation.
The
What?
valve, patent valve, the valve,
Patent
arterial
ductus
ductus.
arteriosus, PDA, which
Mhm.
is, it connects lungs to the
To
aorta.
the heart. Mhm.
And we need that for many different diseases where there's no oxygen getting anywhere. So prostaglandins is given in the slow, continuous drip, okay? What are some side effects? Because you need to know if you're giving it, what would be a side effect that you'd have to stop that medication and call the doctor right away? It's bradycardia.
Right.
Bradycardia.
Yeah.
Also, with prostaglandins, they do run low-grade fevers. It's normal, absolutely normal. Okay, now let's go to the closing, which is indomethacin. Indomethacin is an NSAID. It's like Motrin, but IV form, okay? And indomethacin is given medically or the medicine in up to 3 doses and to try to close it. What it does, it blocks prostaglandins from keeping that valve open from the pulmonary artery to the aorta, keeps it closed, okay? So it stops it from doing it and it closes. What assessment would tell you it's closed before you even did an echo to look at that?
No murmur. You
No
don't hear
murmur,
that murmur
no
anymore.
murmur.
Mhm.
The other thing is with PDAs, many times these are the premature infants. I've noticed in my lifetime, most of them are the smaller infants, premature. Their blood pressures will have what we call a wide pulse pressure. Now, a normal blood pressure on a newborn is 60 to 40, 60 over 40 diastolic. On a PDA, it could be 60 over 16. You'll start to see that number go back to where it should be. And you know that duct is closing, along with that machine, washing machine murmur goes away. And I used to always listen as I'm giving it to make sure, is that murmur going away? Looking if they're on an arterial line, looking to see that blood pressure, taking blood pressures, because I want to know it's closed. Okay, you have a kid with congenital heart disease and you're trying to feed them and they're tuckering out easy. They're getting tachypnic. What assessment do you need to do on this child to see what's going on? Congenital heart disease, heart not working well.
perfusion, do you look at the oxygen level? Like,
All right, oxygen levels going down.
mhm.
Perfusion, it's all right. Why is it going down? Why are they getting tired? They're not getting,
getting that of blood.
they're not getting oxygen.
Right.
Why?
Because
Why?
of circulating.
How about they're going into congestive heart failure?
Yeah, right. Which leads to,
Filling fluid up in the lungs. Remember, congenital heart disease, think of a heart not pumping correctly. Where does the blood go if it's not pumping correctly? It goes back up and it's going to go in those lungs, fill up with fluids. And now you're trying. So listen to the heart sound, the breath sounds, call the doctor, we'll do an x-ray. And of course, we'll give diuretics, maybe something to make that heart work a little better. Could be simple digoxin. And maybe make them MPO for a little bit so they can breathe, because number one is always breathing. Okay, I mentioned digoxin. What do you need to check for with giving digoxin to a child?
Heart rate and monitor for dig toxicity.
apical pulse.
Okay. What about the pulse with children?
It's under 100, you would hold it.
Depends on the age of the child.
Yeah,
That's why you got a vital sign sheet, number one, right?
under 90.
If it's a newborn under 100, maybe a school age under 90, remember, this is age appropriate vital signs. So it depends on the age of the child. What else do we check for? What do you check for with adults?
Blood pressure?
The what?
Blood pressure?
No, it has nothing to do with blood pressure.
I mean, if
about-
you're taking it for a while, you're going to be looking for any signs of adverse effects, like you know. So is that what you're leaning towards? Like, okay.
Before you give a dose of digoxin to any patient, any age, you check the heart rate,
The
check the
apical,
potassium level.
okay, yeah.
We're going to check the dig level. And if a kid is vomiting and a newborn, that might be the only thing you see. Remember, vomiting is signs of dig toxicity. They can't tell you if they have blurry or yellow spots. An older kid might, but remember, age appropriate infants might just be vomiting and maybe a slightly low heart rate, or maybe not. So these are things to remember giving dig. It's tricky giving digoxin to an infant. You got to look at that stuff. Okay, cardiac catheterization. So we've done our EKG, we've done our echo, we have seen some congenital abnormality. Now, in this case, we're going to go for that cardiac catheterization. When they come back from that cardiac catheterization, nursing responsibilities, what's number one priority assessment?
Is that look for signs of bleeding?
Absolutely. Especially children, these are big vessels in relation to their veins, to their bodies. So they could bleed, 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 bleed. So making sure that dressing is clean and dry, that's the number one greatest risk for children, especially infants, for a cardiac catheterization. And remember, keep the legs straight. They can't get out of bed for 24 hours, but they can eat and drink. And after any procedure with younger children, you'll be checking the dextrose. Do a little dex stick, see where's their blood sugar, because they could have gotten too much blood sugar or not enough. So you want to see where you're going. Rheumatic fever. What do you see? What would the child complain of?
Sore throat.
Okay, what else?
Pain.
Okay, what else? Fever, rash.
Rash,
How
right.
about chorea? Walking crazy, stumbling, falling down. And what's the one that we can't correct if it's gotten to that level?
Heart damage.
Right, heart valve damage. So we can correct everything, but we can't change if they've already injured their heart valve, okay? So what causes rheumatic fever? Or acute glomerulonephritis?
Strep throat.
How do we treat it? We
Antibiotic.
absolutely, we're going to give antibiotics, usually a longer term with it. But
Mhm.
we need to tell those parents everything can be corrected except the heart valve. Usually when they start stumbling with this fever and they look like they're getting incoherent, that's when the parents say, I need to get this kid to the doctor. And it's usually a prolonged period of time. Okay, urinary. You have a kid who just had a urinary tract infection, and you're going to teach parents on what to look for urinary tract infections. What might they see, whether girl or boy? What are you looking for?
Sometimes there's like the color of their urine
Okay,
might be
could be.
cloudy, it might be a little different.
They
They
might
might
have
have a
pain.
pain, fever, it depends.
Sometimes it smells,
Yeah. Yes,
frequency, burning, different color. Yes. How do we stop urinary tract infections? Well, decrease. What would we teach parents?
good hygiene.
Wipe
Front to
from
back.
front to back.
You
No
can limit,
bubble baths.
limit bubble baths.
The poor little kid can't get a
Clean
bubble bath.
underwear. Yeah.
Pulling the foreskin down, cleaning underneath, right? Because
Mhm.
that schmegma, that white cheesy stuff, is like a petri dish. It will, grow bacteria in there. So make sure once a day that they pull it down. And that does help it clean. No tight underwear. And they prefer cotton underwear because it breathes. That's the reason, because it breathes. Cryptorchidism. What is it?
Ascending testicle.
Mm, And how do we check for it? How do you do an examination?
Translucent light. Transilluminating.
No, you just touch them with your hands.
Hold-
But what's important about doing that?
The temperature of the room needs to be warm.
It
Yeah.
has to be a warm room. Now, what if they're doing this examination and one of the testicles, they can't find it? What would be a good question to ask that parent?
If it was there before. like,
Exactly. Because sometimes it's intermittent. Very good, Sherry. That was a tricky question. Excellent.
Thank you.
Oh, thank you. All right.
You're teaching us. You're teaching us.
You teach me too.
That
Trust
different.
me. I learn a lot from students too. So remember that. I learn from everybody every day. Nephrotic syndrome. What is nephrotic syndrome? What's that all about? Is it renal failure? What is it?
No, it's not renal failure actually.
Absolutely
That's
correct.
It's protein, the amount of like excess protein in urine, excess protein loss in urine.
As in the kidneys say, protein, I don't like you, goodbye. And you will see the protein in the body drain out. So you'll see it in the urine, proteinuria. You'll also see the protein from the intravascular space going away too. So we know from pharmacology, you need protein in the blood because the way you give medications depends on it. No protein, you need lower doses because there'll be a lot of free drug in the body, okay? Very scary thing about that. Now, we have proteinuria, hypoalbuminemia, the fluids pushed interstitially. It goes all swollen eyes, swollen lips. You see the kid swollen. Now, sometimes we give treatment in order to suck all of that fluid out of the interstitial space. And we give the body protein, which is albumin. Now, just for your information, you don't need to know it specifically, but there's two types of albumin, 5% which we just use for like a bolus of fluid for blood pressure. But there's 25% really jam full of protein. So we give that, it starts sucking all of this fluid out from the tissue, and then we give a diuretic to follow it. How would you know that treatment worked?
You'll see more protein in the urine? No?
Less protein and less edema too.
Less edema. That's one
Yeah.
thing. You'll also see what? Urine output. You're peeing now. You gave a
yeah.
diuretic. You're urinating, and the edema is disappearing. Those are the two things you see. Absolutely. All right. You know, we talked about the urinary tract infection, and I forgot to mention this. So you've got this little infant who had this really bad urinary tract infection, and it was caused by a staph infection. And they gave this child one of those aminoglycosides called vancomycin. And they were on it for, 2 weeks because it was really bad. And the doctor wanted to be sure it was gone. What are some signs and symptoms of toxicity that even after you go home, a parent should be taught to watch? An aminoglycoside, a CIN, a CIN, vancomycin. What are those signs of toxicity?
The ears, yeah, that's
Hearing. So it's ototoxic and it's nephrotoxic. It can kill kidneys and it can kill hearing. Why
Mhm.
do we do peaks and troughs? To make sure they're getting enough or not too much. So after they go home, what would you be telling them to look for?
The amount of diaper that they change.
Okay. And
They might be tugging at their ear.
no, it's not pain.
Okay.
They wouldn't hear you.
Hmm.
The hearing could be decreased. Go like this and they can't hear you. That's how usually we find out babies don't hear. By loud noises, they don't respond, okay? All right. Hypospadias. Now, in the PowerPoint review, you've got a beautiful picture of a splayed penis. It's an older child, but I wanted you to see what they go through. It's pretty intense. Post-operatively, these children, what are some things that are you going to monitor post-hypospadias?
Can you repeat that? I'm sorry.
If you could put your name on this iPhone, is that what you on the side? Would you
It's
put your
Sasha. I'm sorry.
just put it in the chat box what your name is. That's all I need. Okay, so you have a child post-op hypospadias repair. They've taken the foreskin, so they can't do it brisk, so it's a cultural issue too. And they use it for the closure. Post-operatively, what are some things you're going to monitor for?
Infection.
Swelling, redness.
It's a
Well,
penis.
it's going to be red.
It's a penis. What does a penis do? It urinates.
Hmm.
What are you going to do? It's left with a catheter inside there for 7 to 10 days. What do you do with a catheter?
Flush it.
Do nothing. Nothing. Make sure it's inside the diaper because urine will be coming out of there. It maintains the integrity of the lumen. And only the surgeon, the urologist who did the surgery will remove it in 7 to 10 days. You do nothing, nothing. Keep it inside the diaper. Now, this is usually a younger child. Let's say they didn't do it till the kid was 18 months. What are some things you need to tell the parent about activity and safety on this child? Going home, got that catheter in there. The whole penis was splayed.
Easier activities. Mm-hmm.
What did you say?
Like playing easier activities, like nothing like rough.
No rough activities, no riding bikes, no rocking horses. not playing ball, anything that would hurt or damage it. You know, sit there and play cards, play puzzles, blocks, do something easier with that child because that has to heal. Very important thing to teach parents about that. Very good. Okay, Wilms tumor. What is that? What precautions do you all know about?
Don't palpate the
Do
abdomen.
not palpate the abdomen.
Right. Another thing is many cancers require a biopsy, right? You will not do one with a Wilms tumor. And why?
It can spread more.
Right? Because it's just like manipulating the abdomen. Same thing, metastases go everywhere. So on a Wilms tumor, no manipulation, and we're not going to do that biopsy because we know where it is and the symptoms, that's what it is. And they make huge incisions. So when they pull it out, they don't have to tug and pull it tightly through. They really do on them. And I did put those pictures on your PowerPoints to show you huge incisions. And then chronic kidney disease. One of the side effects on children born with chronic kidney disease is osteodystrophy. What are some signs and symptoms of osteodystrophy you might see?
They might have pain. They'll have. It can affect their growth.
It's the growth. You could have crooked bones or slow growth. One of the big things, it's because of a vitamin D deficiency. Okay. So something to look out for. Because the body in chronic kidney disease doesn't produce a lot of red blood cells, what medication might you anticipate being given?
Erythropoietin.
Erythropoietin, yes, very good. All right, let's go to respiratory next. Okay, you got a kid with croup, came into the urgent care and was really, barking cough. You could hear it. Remember it said inspiratory stridor that goes on there. And you had to give a racemic epi aerosol, but they improved. You gave them a steroid and you're sending them home with instructions. What would you tell a parent you need to do to send them home to keep that child safe? What to look for? What does croup go into if it's not treated?
Look for drooling because it can go into epiglottitis.
That's it. Absolutely. So this is something that you will look for. And if they are drooling, you can say this is an emergency. They need to come now. Okie dokie. Epiglottitis. So this kid now croup, now is drooling, inspiratory stridor, leaning forward, garbled voice, comes into the ER. Okay. What equipment and things do you need around that child for safety again?
Intubation kit.
And a trach tray. Because if it's that swollen, that epiglottis is so swollen, how can you stick an endotracheal tube there? Sometimes they do have to do a trach. Thank God I've never seen that. Usually racemic epi, IV steroids, usually we do, all right? But it can happen and it's better to be prepared, like the Girl Scouts, right? Be prepared. Okay, asthma in children. Asthma in children, a common thing that can occur. We know that in asthma with children, there's certain things that we do. We give a steroid inhaler or aerosol morning and night, and then we have our rescue, whether it's called albuterol, Proventil. These are all rescue, okay? Now, you have a child who comes in, who's for the last couple of days getting worse and worse. What is some important information you need to evaluate about this child and asthma and her medicines?
Do they have a spacer?
A spacer, or sometimes they just have that stick that they hold on to like the adults. You can change that to a mask, okay? So whether they need a mask to hold it on or a spacer on the MDI, whether it's an aerosol or an MDI. Remember, those little changes there can save admissions. It's like, well, doctor, this kid's really not gotten the medicine because they don't have a spacer. They lost their spacer. Or this is the aerosol treatment, just a stick. They didn't have a mask. The kid doesn't know how to put his lips around it. So these are key informations that we do need to know for it. RSV. Have an infant, young, who came in diagnosed with RSV. Number one, what would you see in a child with RSV? What is it? What does it mean?
Respiratory syncytial virus.
Yes, it is. Signs and symptoms.
They might have malaise, lethargy for when they're going to be dehydrated. They
Why are
might
they
be,
dehydrated?
you said why?
Why? Try to
Okay.
make you think.
Maybe they're not
But they
drinking
have-
enough.
Have a fever?
They could have low-grade fever. That could be part of
Mhm.
dehydration. Plus, if you have your nose all clogged up with mucus, how can you suck, swallow, and breathe? So the most important thing is to breathe so they don't eat. And that could be the dehydration.
Mhm.
You would also see retractions, right? What are signs of severe respiratory distress in infants?
Grunting?
Grunting is the big one. And remember, nasal flaring,
Mhm.
very specific to infants. So you have a kid, RSV. Now it's been, we've done the specimen, which is a nose swab, found out they're RSV, and you're the charge nurse up on the floor, and you need to put them into a room on your floor. And all you have is semi-private rooms, no private room. How and what question would you ask to put that child in with another child? You have 3 rooms, they have RSV. Which one do you put them in? What's an important question?
You have to think about a child that is immunocompromised for one.
That could be, all right.
One who might be infectious, is it depends on what that other child has.
Well, they're all RSV.
What about age?
Well, not really. If you don't have a choice, you got to put them where. But how about immunization status? Okay, you're RSV, but are they pertussis too?
Right.
Right? You don't know. So immunization status is an important thing to remember. And
Mhm.
remember, if you have any children that are in the hospital with these types of things and you will get them, make sure you teach parents they cannot come out of the room. Okay? Because they could spread this disease everywhere. Very important thing to remember. Now, your kid is immunocompromised, like Sherry was talking about. What is the immunization that we can do? Explain it to me.
You said we can do or can't do.
What immunization are you going to give this child? An immunosuppressed who has heart disease, premature, cystic fibrosis, sickle cell, immunocompromised. We can prevent RSV from occurring. How do we do that?
You don't immunize?
No live vaccines, I know that much. No live.
Well, for sure. What about Synergist?
Oh yes, synergies.
Remember Synergist? What do you know about Synergist?
It's given IM monthly
For how long?
from is it December to March for the winter months.
So winter to early spring for the first year of life.
Mhm.
Okay. All right.
What'd you say it was called again?
Synergist.
Synergies? Okay. Thank you.
SYNERGIS, I want to say. Synergist.
GIST.
Palvizumab. It's palvizumab. It's a biologic. Balizumab. All right, cystic fibrosis, we know is a two-component disease. When you're working with the lungs, how do we treat the lungs?
Have to
I
make
mean,
sure it's clear.
And how
It's
do we
not
do
just
that?
them.
How do we
We
do that?
listen, we drain, we do drainage, we listen.
We're gonna do chest PT,
Just, mm-hmm.
aerosols, postural drainage, get them up and moving. It's
Yeah.
the best thing to do for them.
Keep them
And-
hydrated.
Oh, absolutely, because the secretions will be thinner. Excellent
Mhm.
point, yes. And what about giving enzymes to these children?
Yes,
When
they
do we
get
do
it.
They need it before they eat.
Mhm.
Before they eat. We could sprinkle it on their food, making sure that we increase dosages as they get bigger. And if they're using the powder, making sure that they rinse their mouth out, brush their teeth after they're done, because it can hurt their teeth. Okay, GI. You have a child who comes in complaining of diarrhea for 2 days. What's one of the assessments that you need to include in when you're evaluating that child? Dehydration from diarrhea, explosive diarrhea.
Heart rate.
Okay. Dehydration, it's gonna be
We know they're
elevated.
gonna have metabolic acidosis from that
Excellent.
from that diarrhea. So they
Excellent.
need fluids. We have to be yeah.
Okay. Remember, they've had diarrhea. What does their butt look like? Is it all red and raw? It's as simple as remembering that, because we can do things to take care of that. Can you imagine a kid with a red raw butt that's constantly with this acidy, alkaline
Wow.
stuff can you imagine making sure that we have proper butt care? Yes. Okay, kid comes in, 7 years old, complaining it's been in abdominal pain, a little nausea for the last 2 days. One of the assessment questions, what's one of the most important assessment questions we need to ask?
What type of vomiting?
Where
No.
the pain is?
Where the pain is. Is it a gastroenteritis or is it an appendicitis? There's a difference. And according to the location of the pain. Location of the pain is very, very important. Very good. Okay, so you've had appendicitis and all of a sudden the pain goes away. And of course, now you have a ruptured appendix with peritonitis. So you've gone through the treatment. We've gone through the IV antibiotics, the pain, the NG tube. We've monitored that wound and we're getting ready to go home. And you're sending them home. What are some discharge instructions that would cause a parent to need to come back quickly to the ER? What would be some of those things that you might see would be very
Fever.
alarming? Well, it could be fever.
Inflammation of the site, the surgical site.
Could be. What if they all of a sudden, this kid started with colicky pain, abdominal pain, nausea, vomiting, the belly gets big and distended? What do you think that could be?
Peritonitis.
No.
Infection. Oh.
Remember, those intestines were hurt with all that infection and they're angry. Could be a paralytic ileus. The intestines just stop. Now, why would that happen? Well, think about what you need to do if an appendix burst. All of that infection spewed everywhere in the peritoneum. They are going under and looking and rinsing and flushing and manipulating that abdomen a lot, right? And when you manipulate that a lot, it can cause those nerves to get angry and stop. And that causes paralytic ileus. One of the side effects that we need to teach. our parents about. And pyloric stenosis. What is the first question that you would ask? Kid comes in, infant, 3 weeks to 3 months old, because that's about the ages of it. What would be the first question you would ask the parent?
How they're
The vomiting.
Did it dribble out and just reflux, or is it across the room?
Projectile. Mhm.
Right. What are some of the assessments you might see with pyloric stenosis? Before we do any ultrasound, what can you do? And you say, yep, it is.
Is it that projectile vomiting?
Well, that's
Or-
one of them.
Okay.
Well, can you feel,
Oh yeah, that go ahead. I'm sorry.
can you feel for the little,
The little
You-
marble. the
yeah,
little
that's the
olive.
word you said.
I call it a marble, but it's an olive size. It's a marble. It was an olive. And it is, it's hard. And you can feel it like the right upper to the midline. So when they saying it's coming out, my hand's gonna go very, they're quiet, the mother's arms. I'm gonna feel that upper area below the xiphoid process, and you can feel it. So you know. So these children are NPO, get an IV, we do surgery, and then we slowly introduce the foods after, and they do well. But can you imagine telling a parent of this itsy bitsy baby, oh, they have to go to the OR? So remember, emotional support for those parents. Okay, neuro. I got a little neuro, a little bit all over the place. You have an adolescent going to the school nurse. She's complaining that she's got ringing in her ears. What would be the first assessment you need to do? What question you need to ask? What you need to do?
You can ask if she
Go ahead.
Is she on any like medication?
if she put anything in her ear, if she had she was playing, what is that stuff to listen to again? I'm sorry. I have so much information in my brain. That they listen to, they play their stuff high, and sometimes they might put objects in their ears. You know, I've seen a case where this one adolescent, she had like pieces of pencil stuff.
So
The lead
look
in her-
into the ears
Yes, you
first.
have to look.
Look, I've seen cockroaches inside ears, and they hear this buzzing and stuff in their ears, and they're like, I don't know what it is. They're at sleep, because I worked night shift for 23 years. I love night shift. I felt autonomous working that shift. I felt like I needed to know, so I learned so that I could take care of these patients. Now, during the sleep, crawled up, got into the ear, and they woke up with ringing in their ears. So I looked in and I went, it's a cockroach. So we put mineral oil in there. It smothers them. Then they take these little alligator clips and get it out. But any sort of condition where they're complaining of pain in their throat, look at the ear, something eye, look at the area first, because that could give you your answer. And then if that's not, all those other questions, Sherry, would be perfect. Okay?
Yes.
Meningitis. We know there's viral and there's bacteria. So what procedure are you going to be knowing is going to happen? Get prepared for. I couldn't hear
Spinal
you.
tap?
Yes, a spinal tap. So it comes out, it's a bacterial meningitis. You have elevated proteins and you have low glucose.
You're going to be starting I'm sorry.
No, very good. So we know that bacteria love sugar. So your sugars are low in the spinal fluid, and your white count's going to be off the wall, and it's going to be cloudy, won't be clear. Our priority treatment is IV antibiotics. Yes, Sherry. Excellent, excellent, excellent. Okay, seizures. Tell me about safety. You walk in a room, the kid is tonic-clonic. What do?
Move sharp objects, safety precautions.
Call
Send
the
them to the
rescue team.
side. Yeah.
Call the rescue team. You don't know how long it's going to last. Some of these children will require an anti-seizure medicine usually diazepam or Ativan, lorazepam. Lorazepam is usually the number one, get the lorazepam. And then after that, they'll maybe start the phenytoin, dilantin, if they need to, depending on the patient condition. It could be just a fever, we don't know, but we will give lorazepam if it goes on and on, because we worry about respiratory. Okay, good. Okay, this one's for you, Taylor. Myelomeningocele, what's your biggest concern?
Bladder and urinary.
Remember that meninges and the spinal cord is all up in that big purple blob on the back. It has stretched those nerves from the lower extremities. That's why you have, sometimes they're paralyzed completely on the waist down, sometimes partially, but we're concerned about urinary function and constipation. Very important things. So some of these children will require catheterizations every 4 hours for life. Now, that being said, if they have to be catheterized every 4 hours for life, what is one safety concern we need to teach that child and that parent? What to look for in this catheterization?
Bleeding afterwards.
How about latex?
Oh yeah, after, yeah.
These kids are on latex allergy from the
Yep.
moment they're born,
Mm-hmm.
so that we don't get to anaphylaxis. Duchenne muscular dystrophy. As I said, this is one of the most common muscular dystrophies that HESIs and NCLEX love to cover. It is your males ages 3 to 7, and it's a progressive decline in muscle strength. You see big arms, like hypertrophic they called, and hypertrophic calves. And they start, the big curvature, lordosis in their back. They'll be waddling, they'll be stumbling, falling over, and they bring them to the doctor. They're going to do an examination, which measures muscle strength. What is the name of that? And what are some? Yeah, go ahead. Electromyography. It's an EMG. What do we need to be prepared for to teach the parents and the child when they come back from this procedure?
They're gonna be sore.
It does. It's like doing 100 push-ups when you haven't done any. So, because they're spasming the muscles, so they're making them work. It's like exercising. So, and making sure to tell the parents it's only temporary. It's something that will not continue.
Professor Borger, I have a question regarding the myelomeningocele as it relates to the latex allergy. Is that because of the continual use of the catheter, or
It's
or
the
are they born with
continuous
it?
use of
the
latex,
Okay.
the exposure. I'm
Mhm.
latex allergy.
Okay.
Because back in the early 80s, okay, when HIV came about and we understood it was there, we were given gloves.
Mm.
I worked in the newborn intensive care unit, which was a huge newborn intensive care unit. And I had to scrub my hands to my elbows every time I walked in that unit. And I had to put on gloves to go inside isolates, and they only had latex. So I scrubbed the skin off, put latex on, putting them in these hot isolates, and now I am latex allergy because of it. Same concept, over and over exposure. These are the things that happen when you become a nurse, right? That and bad backs if you're with adults. Okay, you have a kid who has these eyes that are twitching. They have nystagmus. What are some things that we can do examinations to look at the eyes? Something you taught in health assessment.
Dilation. Pupil dilation.
You're always
You
going to
cover,
check.
you cover the normal eye, the one with the normal vision, to try to get to use the affected one, the one
Well,
with the
that's amblyopia. That's the lazy eye.
Okay, oh yes,
But,
you're right.
but in any eye condition, remember there is that 6 cardinal positions of gaze, checking that out. That would be a good start in an assessment. Okay? Any eye condition, that's something that you should be checking for. Now, what if you had a kid fell down, I say fell in a pricker bush, and now complaining of severe pain in one eye, it's watering, it's painful. They go to the doctor, and what do they do? What's the treatment? Well, there's something called a Fox shield. It's a hard eye patch. Put them on both eyes and get them to a pediatric ophthalmologist right away. Remember, never pull out anything embedded in an eye. If it's floating, you can take a tissue and get it out, but you cannot do that because you need to get them to that pediatric ophthalmologist in order to save the eye, whether it's an ER that's peds or a pediatric ophthalmologist. Okay, endocrine. So we've talked about growth already, and we've talked about children and hypopituitarism. What's the most thing that we are going to be monitoring every visit?
Height and weight.
Height and weight. We can see, are they growing in the proper way? Yes, very good. It's also with hypothyroidism. Growth is the difference between adults and children. They all have cold intolerance, they have sparse hair, dry skin, constipation, but it's the growth because we're done growing when we're adults. Hypoparathyroidism. What does the parathyroid monitor, and what would hypo cause as a symptom?
Isn't that the low
Calcium?
calcium?
Okay, so if
And
you don't
then
have
it will
enough,
cause like tetany.
oh, that's hyper. Tetany is in
Oh.
spasm.
Okay.
Hypo is weakness. I'm glad you said that. Yes.
Okay.
Hypo is weakness. So if you see remember magnesium, calcium are both about muscles, and they both work very similar. So hypoparathyroidism, not enough calcium would cause muscle weakness. Could be falling over or poor grasp, carrying a lunch tray and it falls down because their hands can't hold on to it. Little things like that, okay? And we treat it with calcium, very simply. All right, DKA. DKA is this really big disease, and many of you are scared of it. It's just basically your pancreas secretes an enzyme called insulin. And insulin goes into the sugar and changes it into a form the body can use. So it uses carbohydrates. When you don't have enough insulin, and you're going to see blood sugars elevated like crazy in the body because you can't use it. So it's still going to be there. The body said, I'm hungry. So it goes to the protein and starts eating it. And we've already said protein is going to be side effect. It's going to see ketones in the urine. So if you have a kid suspected DKA, elevated blood sugars, and proteinuria, that's without even looking at the kid. You can just do a blood sugar and a urine and see it. What do you do first? What's treatment? What do you know the doctor's
Insulin?
going to order? Are you going to give the insulin?
IV.
Mhm.
Well, you first need to start an IV. We need to give fluids. We need to dilute that sugar. And we're going to give a continuous, slow infusion of regular insulin. Now, I ask you, how are you going to monitor how much insulin in this infusion you're giving? And how do you change? When should you change it? You
When
just give one dose, keep going?
when their levels go down, their sugar levels go down.
Right. So part of your care plan when you're monitoring a child with DKA and regarding the insulin is you're going to be monitoring blood sugars every whatever. Initially, it might be every 15 minutes, might be every 5 minutes, depending. And as the blood sugar goes down, you're going to be adjusting the insulin drip accordingly. Usually the physician will write a scale there for you to do, or you tell them and they keep telling you what to do with it. So that is a very tedious task, but if we let it go too low, then you're in hypoglycemia. We don't want to do that. Now, children do have type 1 diabetes and they live with it. And many of them are taught, you know, we teach them to be normal kids. I mean, just because you have diabetes doesn't mean you can't go and play sports. What are some things prior to playing sports should a child do, and how should they be prepared for whatever results that they're seeing?
You should always check their sugars before exercising, and if it's too low, eat a snack so it raises it. So while they're exercising, it has enough space to go down.
Right, and then to keep them hydrated. Excellent, Nikki. Excellent comment there, because these kids should be normal. You know, checking if their blood sugar is 200, go, because that's not too high for a child with type 1 diabetes, and they got plenty of sugar to start, and always have the snack there, you know, as we go along. Very good. All right, some childhood diseases that we see. You know, I never I never worked closely with impetigo before until my grandson came here last year. And my daughter said he had a mosquito bite and he itched it so much and it was scabby and juicy, and yelled at his son from itching it too much. I took one look and said, that's impetigo. So how do we treat impetigo? What is impetigo? It's a skin infection.
Antibiotics.
Yeah, we do antibiotics.
We keep it covered.
No.
We don't.
Light, is it light topical ointment? Spray evenly.
Yeah, that Bactroban stuff, the muprocin, and oral antibiotics. Now, we don't want to keep it covered because it will keep heat in there and it will cause more juice. And the juice makes it spread, that fluid inside. So if at all possible, keep it open. Highly, highly contagious. I had to keep him home for a week. And of course, in my house, and I had to treat it. Twice a day, the Bactroban, and twice a day, cephalexin, which is Keflex. And it treated. Now, depending on your type of skin, and because of this, and this was like a huge, you know, sore that he had on the back of his leg, on his calf. What would the skin look like after it's healed?
Dry and crusted.
It's already healed, it's gone away.
Hmm.
You might see some redness there, or you might see keloids, depending on your type of skin. But usually it's just some redness that are there that usually in time will go away. Okay, conjunctivitis. Kids, they love touching their hands. They like to touch everything. So teaching these children, sometimes the physician might order an ointment to go in these children's eyes. We know, clean it from the inside out. Don't use one, go to the other. Use a cotton ball for each or whatever you're using. Washing hands, absolutely. I also teach parents to change their pillowcases every night, which is something nobody thinks about. That's just from me to you. That's just from me to you, telling you. It really makes a difference, especially you who have children. So they give ointment and they put it in a child's eye. What do you need to tell that child? What's some teaching?
It's going to be blurred for they're
It
going to
does.
have blurred
Can you
vision.
imagine all of a sudden you can't see well out of an eye and you're 4 years old? I'm going to go bonkers. But you say, just keep your eye. It's going to be okay. It's going to be blurry and it'll go away. Your vision is okay, because they get scared. Remember, everything, they're going to die. I mean, especially those young kids. I'm going to die. I'm going to bleed out. God is punishing me. This is all part of it. Okay, you have a kid who is out playing in the fields with his friend, comes home and you found a tick because it was on the neck and you could see it, and you took it out. Next thing you're going to do, check all the body for ticks. All right, there's no more ticks. You got the tick out. A week later, you see a red spot and you see a fever. What do you need to do? Got a bullseye rash going on.
Get them to the doctor. It could be Lyme disease.
There you go. And we treat it with,
Is it antibiotic?
it's antibiotics, yes.
Okay.
It's not a viral, it's an infection.
Mhm.
Usually they'll put them on azithromycin. But again, it's up to the physician. I've seen Lyme disease go undetected for a long time.
Yeah.
And then finally they figured it out. Okay, chicken pox. Kids get, I mean, even if they've been immunized, kids still can get chicken pox. We
Mhm.
can still get it. When are children infectious?
When it's oozing,
What did you
Me
say?
too.
when it's like open and oozing.
They are
Within
infectious.
the first
then.
2 weeks of being infected, the incubation period.
2 days before the
2
rash.
days, I mean, 2 days,
2
yes.
days before the rash appears,
Mhm.
up till when it's all crusted and dry.
Crusted. Mhm.
As a nurse, I've seen children come in, and if you see rashes, all different stages of healing, they need to go immediately into an isolation room. You always suspect it. And that's the way I've been taught with it. And what's hard is those 2 days before the rash, that's when they're spreading it to other children. So those children need to be notified. Your roommate in your class has chickenpox, you were exposed.
Hmm.
And head lice. What do you check? My daughter had it 5 times in kindergarten. And she had hair down to her belt buckle,
Mm.
as thick as this.
Wow. Wow.
Let me tell you, I was tired of washing everything. I'm tired of the fine tooth comb getting all, and this hair, fine tooth comb getting all the nits out. Because you look at the shaft, okay? You go down to the shaft and you look and you inspect where it comes out of the head, the hair follicle. That's where they nest in there, okay? So that's how you inspect it. You treat it with Nix was the thing, or for hair lice, and then wash everything. I had Afghans and pillows and blankets and unbelievable. And I was in a townhouse with a tiny stackable washer and dryer. I think I did 10 loads 5 times. I was so tired of it. Anyway, all right, infectious disease, infection control, things that we need to know about that. We're almost done. So low neutrophil counts. What is a neutrophil count? What is a normal? Do you know? Or what do you consider low?
400 or 500 as well.
400 to 500 is low. What does that mean? Neutrophil count low.
They're susceptible to diseases and their immune system's down.
Absolutely. Good job. These kids are, and depending on their condition, can go into septic shock, especially if they're immunocompromised already. But a normal kid, which means not immunosuppressed, neutrophil counts of 400 to 500. This is a kid, is priority. You're first to be seen if you've got a group of kids. That's number one. You need, of course, washing your hands, mask if you sound like me, even though I'm not infectious, but mask on, go in and evaluate that child. Those kids need antibiotics now to help them. All right, in the hospital, the number one thing that we could do to prevent infections for other children as nurses is washing hands, washing hands. I mean, that really in itself is the number one thing that we could do to help our children not get disease, even adults. You have a child, excuse me, who's immunosuppressed, whether they're, congenital heart disease, whether they're sickle cell, cystic fibrosis. One of the things that we do at discharge teaching is when it's an emergency to seek medical care. What's the number one thing we tell them to check? Immunocompromised. What is a problem? What's priority?
Fever.
Fever.
Fever of 100.5 or higher, seek medical attention now. Because if you're immunosuppressed, you have a fever, there's nothing to fight it. You're going to get sick really quick. Excellent. And then immunizations. These kids get 2, 4, 6 months, 15, 18. I mean, it's crazy. Sometimes they're giving 3 or 4, 2 in each side.
Right.
What happens if those, let's say the legs are red and swollen and they got a low-grade fever? What do you need to look out for? When do you need to report it? Or what do you need to do to help these children?
Maybe sepsis.
Fever's normal.
How do you know? Yeah, I was gonna say, how do you know, like what's an adverse reaction versus what's expected? Because isn't it expected for them to get a little redness with the shot?
They're gonna get redness, they're gonna get a little swollen, they're gonna get fever. So we'll tell you Tylenol or Motrin, depending on the age, give it at least every 6 hours for pain and for fever. Cold packs you put on it will help with the heat and swelling. And then bicycle the legs. Get that immunization moved in. You're getting those muscles moving. So a fever, you don't have to report it to the doctor. You don't need to call 911. It's the body's response to the immunization, trying to make up antibodies to protect it in the future. Okay?
Isn't it if you are sick already, you hold off on giving a vaccine?
Exactly. Because if you're sick, how do you know if it's because of the immunization or because of an illness, the fever? So absolutely, you're not going to be giving it to a child with a fever. That's why many kids are getting their 15-month immunizations at 2.5 years, because they've been sick. And it's okay as long as they've been getting them. Thank you for saying that. Very good thing. I didn't mention it. And then our last section, and there's about 4 questions on acid base. Now, Sherry already answered the one about DKA. No, not DKA, diarrhea and metabolic acidosis. So diarrhea causes metabolic acidosis because the lower bowel has all the enzymes from digestion, which are alkaline. So diarrhea is getting rid of alkaline. So what is left? Acid. So that's that. If you're vomiting, what does your stomach have? Acid. So you're getting rid of acid. What is left? Alkaline. So it's metabolic alkalosis. I can't make this easier for you guys. All right.
You know what? I was told there's an easy way to remember it for people who have an issue. Just think about the acidosis with the diabetes. Think about where I'm going. I'm not going to say it. I don't want to say it, but the acidosis, diarrhea.
Diarrhea.
Yeah,
Okay.
I don't want to say it.
It's okay.
Yeah, I see. I was told.
Okay.
It has
Well,
helped me.
there
and
are,
I know
listen,
I know it.
There's jingle wingles for everything, and it's how I remember it too. I'm trying to put it in a way that you can remember.
Right.
Enzymes, alkaline, go away, what's left? Acid stomach, coming out, what's left? Alkaline. Okay, now what about with metabolic acidosis? Why does the lungs do these Kussmaul respirations? Respiratory alkalosis is trying to compensate. So you have acid. What do you want to do? Alkalosis. And it has to do with lungs. So that one's respiratory. Okay. And then what about a child who's hyperventilating? What would you see?
Respiratory
Respiratory alkalosis.
Respiratory alkalosis. So this is all I got for you. I've gone through all the HESIs. I think I've helped you think a little bit. I think it's going to help you think when you get the capstone. So just remember, look at what I'm looking at. What diagnosis? What do I know with this question? that refers to that. Because remember, there's distractors everywhere. So pull up the question, what am I looking for? And then through process of elimination. And yes, those answers can be that easy. Okay? Don't second guess yourself. And as one student told me, don't think that 4 questions on a select all is too many, that there needs to be less than, or 1 is not enough. Don't do that. Just select what you know is right and don't try to overthink it like that, okay? I think you guys, you've listened to me, you've been thinking, and I think you guys are going to do great. So will you please message me and let me know how you did?
I will.
Thank you so much, guys. Have a great Sunday. Thanks for joining
Thank you.
Thank
I
you.
appreciate, I appreciate you taking time out on your Sunday.
me. It is my pleasure.
Yes.
And I will be sending it to all of the classes.